This discussion is going to look at skeletal muscle relaxants. Not a group of drugs we see a whole lot of, but certainly they can be used in some instances. There's probably some instances where even just as students you've heard of patients utilizing them. What I'm going to do is go through, again, the basic application, discuss some of the more common types, have you look into your textbook for some other names of common types of skeletal muscle relaxants. Just talk about how they're used, kind of theoretically how they could be beneficial for individuals with musculoskeletal injury. So an overview of what we're going to discuss. We're going to talk a lot about the basic physiology and looking at the nervous system in general, and also kind of breaking down the difference between muscle spasm and spasticity. So when you're categorizing muscle spasm versus spasticity, those are two separate things. Talk about what the difference is, and again, like I said, even prior to that, go through a general overview of some actions and physiology of the nervous system. Explain the uses of different types of skeletal muscle relaxants, particularly for what we would see in a lot of our common patient populations, and how they work and why they get used. And then obviously, like we do many other times, explain the role of the athletic trainer as far as managing a patient who is taking these drugs. So basic overview of our nervous system. We have our two main areas of the nervous system. We have the central nervous system and the peripheral nervous system. So obviously we know the central nervous system is going to be the brain and the spinal cord. The peripheral nervous system is as those nerve roots kind of branch out into the rest of the body. That would be referred to as our peripheral nervous system. You also have another division being the somatic versus the autonomic nervous system. So the somatic nervous system would be the motor portion of our nervous system, or the voluntary portion of our nervous system. So when you move your arms, move your legs, basic somatic nervous system function, versus the autonomic nervous system, which is the involuntary part of our nervous system. So our heartbeat, our respiration, those things, the things you don't have to think about doing, that's your autonomic nervous system. And then the autonomic nervous system further breaks down into something we're going to talk about on the next slide, the sympathetic and the parasympathetic nervous system. So we know that the sympathetic nervous system, again, is known as our flight or fight portion of the autonomic nervous system. The parasympathetic nervous system is the part that kind of regulates us at rest, and it's sometimes referred to as the rest and digest portion of the autonomic nervous system. So here's a breakdown when you look at the parasympathetic and the sympathetic, and this for most of you should be a review, but this picture kind of breakdowns and illustrates the actions of what the sympathetic nervous system, the sympathetic division versus the parasympathetic does. So if you look down the one side, the sympathetic division, you have dilated pupils, you have weak stimulation of the salivary flow, so that's where you get the dry mouth from. In the heart, the heart rate gets faster, the bronchi dilate. So if you think about everything that has to happen when you're stressed, or your body has to run, or even just think about, like, for instance, when you exercise, if you're running sprints or something like that, what your body does to do that. Your body at that time isn't concerned about digesting food. It's concerned about getting blood flow to your muscles, again, your heart rate accelerating, your respiration rate going up, versus the parasympathetic division, you have the opposite of that happening. So the parasympathetic, the pupils constrict, the stimulation of the salivary flow happens, your heart rate decreases, your bronchioles constrict, the actions, your gastrointestinal system is active. So, when you think about what happens when you eat a big meal, okay? When you eat a big meal, now the blood flow and all the action has to be directed towards your organs, particularly the organs of your gastrointestinal tract. So this kind of illustrates that. So understand the differences between what goes on here And again, like I said, this should be something that most of you have covered at some point in time, breaking down the sympathetic and parasympathetic portions of the nervous system. Now, the differences between spasticity and spasm. When you're talking spasticity, it's generalized rigidity of skeletal muscle. So this is something that is central nervous system mediated, and what is happening in individuals who have real spasticity, again, difference between spasticity and spasm, they get at such an exaggerated stretch reflex. So remember, the muscle spindles are those proprioceptors that when they're stretched really fast, they cause a really strong contraction. Well, in this instance, it's very exaggerated, causing a major rigidity of the muscles in that region. Okay, and that's going to cause increased activation of those alpha motor neurons. This is the type of thing you see in people who have had major trauma to the central nervous system, have cerebral palsy. This is what you see with that, and it's an upper motor neuron complex problem. So this is much different than what is physiologically going on when you're talking muscle spasm. And what's going to be needed for this, the type of muscle relaxant drugs that are going to be used for this are considered much more direct acting. They're not as general and central acting as you'll be using with muscle spasm. So they'll have a much more direct action, particularly to individual cells, in order to decrease the rigidity here. Okay, so next we're going to be talking about muscle spasm and how that gets dealt with. Now, this is what, in most settings, what we would, as athletic trainers, would kind of be more exposed to is more muscle spasm, which is an increase in involuntary tension of the muscles. So you probably have talked about in therapeutic exercise and modalities the pain spasm pain cycle, where due to injury you get pain, the muscles around the region will create some tension, which in turn will create more pain. This is what we look at as far as the muscle spasm that we see as athletic trainers typically. If you're in a different type of work setting, where, again, for instance, you may be dealing with a different population, there is the chance that you would be dealing with somebody who has spasticity, maybe someone who has cerebral palsy. Now, obviously, our role with that individual would be much different from a rehabilitation and treatment perspective than it would be in dealing with, again, somebody with what we classically see with muscle spasm. So, again, it's a good idea to be aware of the ways to manage spasticity, but from a rehabilitation perspective, we really wouldn't deal with it as much. Our role with that patient population would be a little different. So here we're talking about the increased involuntary tension. The question is, with skeletal muscle relaxants, and we'll address this a little bit more later on, they're not typically a first-line treatment to obviously deal with this. So, for instance, if you look at the picture, you can see this individual. If you look at their low back, the spinal erectors are really tense. I mean, you can see they almost look like little rods in the lower lumbar spine area. The idea here is you will use centrally acting skeletal muscle relaxant drugs to produce a relaxation effect. Again, the question becomes, is it really effective? And I'll talk about some opinions I have on that later on, but that's how this type of muscle spasm would be dealt with. Muscle relaxant drugs, just some general information. The kind that we're primarily going to be talking about are more central acting on the central nervous system impulses. We typically are not going to be using a lot of direct acting, peripheral-based muscle relaxant drugs because of the fact, again, the difference between spasm and spasticity. Those types of skeletal muscle relaxant drugs would be used for individuals who have what would be classified medically as spasticity in the muscles. Again, that would be your cerebral palsy patient or patients who have had major trauma to brain and spinal cord. Overall, we're dealing with a small group of drugs here. Many times they're often combined with other pain medications. So they'll be combined with acetaminophen, they'll be combined with aspirin, and even in addition to those, they may even put caffeine in with them as well. Those combinations do at times happen. The idea here is that you're trying to get general relaxation of the muscles. Now, as athletic trainers in rehabilitation, we use other physical agents to do that as well. So we will look to combine the actions of these drugs with what we use in rehabilitation. So for instance, things like, moist heat, superficial moist heat, we use as a physical agent to produce general relaxation. So we'll be using those physical agents in addition to these pharmacologic agents in working on reducing the muscle spasm. Again, they're commonly used for back and neck pain. That's probably where a lot of times you'll see the application of this. Again, there's a question as to how effective or ineffective this is. From my personal experience, I have seen if you have an individual who more or less can't get over the hump with just the physical agents, sometimes giving somebody something at night, and then we'll talk about how they're usually prescribed, but a lot of times they'll be prescribed to be given at night because of the sedation effects of them. Can sometimes, I've seen that be beneficial for people to kind of get them over that hump or that plateau in their treatment. But just know it's still kind of questionable as far as the research and the overall benefits. And again, like I said, this a lot of times won't be a first-line treatment. It'll be suggested, in working with your physician, they will usually go with the physical agents and exercise and things like that first before they go to something like this. And if it becomes a problem, then it will be a something that the physician may choose to utilize in addition to what you're doing in rehabilitation. So the pharmacokinetics of muscle relaxants, most of them have an onset between 30 and 60 minutes. Table 4.1 on page 58 in your textbook has some different descriptions and some characteristics of different skeletal muscle relaxant drugs. They're metabolized by the liver, excreted by the kidneys. The duration could go anywhere from 3 to 24 hours, depending on the drug. So that will kind of vary as well. They could be administered via oral, intramuscular, intravenous administration. A discussion post question I'm going to have you address. So with all of this duration of action and just kind of based on some of the side effects that go on, or even just the action in general, what's the significance of the duration of action when dealing with, let's say, athletes? And what considerations would have to be looked at in the prescribing a skeletal muscle relaxant to a very active individual? Even if we don't look at athletes, just look at active individuals. So, and then what I want to look to see kind of going on here is when you bring out points, kind of cite some passages or something from your book so I could kind of see that, again, you're kind of going and understanding the application points here. The pharmacodynamics, so kind of the effect of the drugs on the body. So we know they work at the central nervous system. As far as the overall mechanism, there's not an exact thing that can be pointed out. The main things that we look at is, one, sedation, so just a general relaxation effect on the body, which would just naturally cause the spasm to relax. They also think that there is an inhibitory effect at the receptors. So at those individual receptors for the muscles to cause them to cause that tension, they inhibit those receptors from getting those signals and do that. And that's in the end what allows that individual spasm at the muscles to decrease. So basically an overall relaxation effect on the body, and that you look to have an inhibitory effect on the individual receptors. Here's some of your adverse effects and interactions. So again, we know that it's a sedation or a sedative effect from the drugs, which we believe is part of the main benefit in kind of reducing that spasm. So obviously that's going to cause the person to possibly have drowsiness, which is part of the reason why many times when these are prescribed, particularly for active individuals, the instructions are usually to take them at night before bed. And again, so obviously kind of going on with that, you have some of your other more sedative-based effects that you would get with these drugs. Very high possibility for dependence, tolerance, and withdrawal. So there's a concern there that you need to make sure that these are taken appropriately and that a person does not start to develop problems with these. They are controlled substances, so that would be something that would have to be taken into consideration as well. You have to watch for allergic reactions, and they shouldn't be combined with any other type of CNS depressant or alcohol because they would have an additive depressant effect on the nervous system. So with skeletal muscle relaxant drugs, you also have the potential for anticholinergic effects. So if you remember, cholinergic is referring to the parasympathetic nervous system, so it's anticholinergic. That means it could basically block those cholinergic receptors. So you have the potential for certain side effects associated with that: the blurred vision, constipation, decreased sweating, dry mouth, increased heart rate, pupil dilation, increased intraocular pressure, urinary difficulty. The most common skeletal muscle relaxant drugs these are associated with are Flexeril and Norflex. So, and again, you just need to be aware of other drugs that may have similar adverse effects that the individual is taking. Your book talks about and mentions malignant hyperthermia. So this is a disorder that is usually seen in individuals who've been under some type of anesthesia. So, and it's basically talked about here because it references muscle spasms. It's associated with muscle spasms. There is a potential genetic predisposition that puts people at risk for this, again, particularly for individuals who have a sensitivity to anesthesia. So you have your signs and symptoms associated with that: the tachycardia, the tachypnea, contractures, cyanosis, skin mottling, fever, hyperthermia. This can also happen in athletes who exercise in hot, humid conditions for a long period of time. You can have a progression from heat stroke to malignant hyperthermia, and a lot of times what you will see with this, in addition, when you're talking the malignant hyperthermia, is something called rhabdomyolysis, which is a catabolic breakdown of skeletal muscle, which will cause the proteins from the muscle to leak into the circulation. And a lot of times what that will do is cause other issues, more particularly issues with the kidneys. So very common to have possible kidney failure, destruction of the kidneys because of the leaking proteins into the general circulation. So that's something else that is just associated with the whole muscle spasm process. So to kind of be aware of that, again, you're usually probably not going to be dealing with the whole concept of it being associated with the anesthesia and the genetic issues associated with that, but there is a chance that with the environmental conditions, which again, the genetic trait can be present in somebody that would suffer from the hot humid conditions, but it can certainly, but it doesn't have to be exclusive to that individual. So some of the more commonly used skeletal muscle relaxants with the brand name drug in the parentheses are listed here. Again, as I talked about before, they can be combined with other analgesics, again, most commonly being acetaminophen, aspirin. There are some combinations that will also include caffeine with that as well. So again, make yourself aware. Again, look at table 4.1 in your textbook as well, as they will be going over some of the other drugs. Again, that will also go over onset of action and duration of action for the different drugs as well. So with the role of the athletic trainer, again, you want to utilize your modalities first. Use what you can use, your physical agents and rehabilitation to try to control the issues with muscle spasm first. So your heat, cold, your different forms of electrical stimulation could all certainly be used in various ways to treat muscle spasm. Even if an individual, a patient, athlete is on a skeletal muscle relaxant, they still have to do rehab. So they should still be going through a rehabilitation process to truly fix the problem. Again, in some instances, it may be deemed necessary by the physician to attempt to use a skeletal muscle relaxant if the problem just doesn't seem to be getting any better. It could just kind of work as another adjunctive treatment in that. Be aware of functional deficits. Again, particularly with the skeletal muscle relaxant, and physicians will know, especially physicians with sports medicine backgrounds, if somebody's active, what skeletal muscle relaxants are going to be the best as far as for the individual, so that during the day they're not having any adverse side effects, most particularly the adverse side effects of the drowsiness and sedation during the day. That'll kind of be, and you need to be aware when scheduling therapy that could potentially be an issue. So that's where being aware of the drug that they're using and what their duration of action is could kind of tell you that. But it's really important, and a physician prescribing these will likely cover this as well, but it certainly doesn't help or doesn't hurt for them to hear it twice. Make sure you're educating the athletes, particularly on alcohol, other medications, and that'll hopefully be something that initially they will be talking with the physician with anyway, but certainly, your role as a healthcare provider can even add to that, to the education with that as well. And be aware of dependence issues. Okay, they are controlled substances. Individuals can become dependent on them, so you want to make sure that none of that develops, and be aware of those warning signs. And here are your learning outcomes. So again, reference all of these points. Make sure you complete the discussion board post question as was discussed during this lecture.